and welcome, friends. Today we have none other than one of the best surgeon orator par excellence, Professor Iype Cherian, with us, and he's going to talk about Cisternostomy. To chair this session, we have none other than Professor Vladimir Benes from Prague. On behalf of the Education Committee and the President, Professor Yoko Kato, I welcome you to this platform of online webinars. Professor Iype, you may please start your lecture.
Thank you, Raja. About 10, 11 years back, I was in Fujita, and I can say for sure that it changed my life. I am, and I will always be a student for Professor Kato and Sano. I owe them all the skills that I have, all my stupid doubts and everything I learned a lot from them. So there's no question about that. So first of all, big respect to Professor Kato and Professor Sano. I would start to share my screen right now. Okay. All right, so this is a very common scenario all over the world. It's one of the most common scenarios. In fact, the most common scenario, which outweighs all other surgeries in the world. Often done by residents, often done by the most junior people, often done at night, often done without a microscope. And, you know, it's a win-win scenario for all. You see the consequence now. You see the consequence. This is what happens usually. And it is not, I mean, if people think this is not common, it's very common. We have all seen it during our residency days. We don't see it anymore because for me, I do cisternostomy, and for most of the senior consultants, they don't go to trauma. But if any of the junior consultants or junior residents are here, I'm sure they see it not on a daily basis, but definitely on a weekly basis. This is what they see. And people call this brain fungus, malignant brain swelling, a lot of names. And this is the beginning of fear. And that fear of so-called malignant brain swelling, whenever this happens in an aneurysm, whenever this happens in a trauma, that urge, adrenaline urge to stop everything and just get out. So this is what happens, and this is the consequence, and this is how neurosurgical, you know, the neurosurgical world is treating trauma. So I want to ask, why did decompressive hemicraniectomy stay for a century? Why did it stay for a century? Many reasons. One is trauma surgery is emergency, and it's an unplanned surgery. I'm sure that a senior professor would not like to go at 2 a.m. in the morning, put the microscope in and sit and open cisterns. I mean, this is something that would wreck an already wrecked life of a neurosurgeon. So nobody wants to do that. So it's a win-win situation for a senior neurosurgeon. Now the junior resident, he gets to see the brain. Okay, he gets to see the brain, play around with the brain. It's a win-win situation for him also. And moreover, it's a win situation for the companies who manufacture and sell cranioplasty to developing countries. You see, 5/6 of the world is developing, so-called LMIC. So these countries have the majority share of trauma. And the Western-based companies, this is the largest business. It's not spine implants. Believe me, it's not spine implants. It is this ICP monitoring and cranioplasty plates and all those pre-planned cranioplasty plates now. This is a big industry because every day you have 3 or 4 in a big hospital. And imagine all these guys who get who get their DZ done, they'll be having cranioplasties too. So gone are the days when people are putting the flap in the abdomen and in the gluteal region and all those places. No, nobody. So this is now, people think it is modern right now, but DC is a 100-year-old surgery. Now, microsurgery is always kept as a costly option because of monopoly. Paper writing, statistics is promoted. That is a new fashion right now. You see a neurosurgeon, people are always looking at how published is he. Yes, of course, it's good to be published, but it is better to have skills. It is useless if you don't have the skills and is published. It's like knowing how to drive and not having a car. So, most journals, they are funded and supported by industry. It's sad, but it's the truth. And vice versa is true too. Because you take any journal, Operative journal, there'll be pictures of all the big companies' stuff. I'm trying to make an exoscope right now, and the cost that we are getting to make this exoscope much better than the present day microscopes is nothing more than $200,000. Okay, with robotics, with navigation, everything, it's not more than $200,000. But how many microscopes would you get at $200,000? At $200,000, you will not get even the second-class microscopes. Okay, and maybe the second-hand microscopes you get, used ones, but not the first line. A Pentero is $1 million. A Calstoscope, okay, it is costly. But the simplest exoscopes can be made at $25,000. $25,000. Surgery, microsurgery is kept as a costly option, and that is why it is not accessible to people in 5/6 of the world. 5/6 of the world's neurosurgeons. Microsurgery is not really an accessible option. And another sad part is that big trauma surgeons, if you go to trauma meetings, most of these guys are data collectors. They are data collectors. I am saying this with, I may be putting a few people off, but this is the truth. They are data collectors. They don't have any skill. I don't know why they're calling themselves neurosurgeons, actually. They should be neurodata collectors or something, but this is a fashion now. You go to a trauma meeting, a big trauma meeting, the world neurotrauma meeting or something, and you'll have a guy talking about, at least one guy talking about the technique of doing a decompressive hemicraniectomy. That is like the technique of milking my cow or something. I mean, milking my cow is more difficult, actually. So, I mean, what technique is technique of decompressive hemicraniectomy? And you will have a lot of guys sitting and listening to it. It's at most, when you go to a meeting like this, it's highly entertaining, actually, So this is another example of stupidity surviving despite we being aware of it. All right. So this is, don't think that I am attacking or anything. Okay. I'm just telling the truth. If I attack, it will be much, much worse. So, I mean, I've been talking to a few guys here, and, it's become a fashion right now. So DC, it stayed for a century, and microsurgery is not come into trauma only because of these factors. And the sad part is, most of these young residents or young neurosurgeons, they be try going for a company sponsored fellowship somewhere. They'll go for 6 weeks or something. They'll stay there for 6 weeks. I don't know what in heavens will you understand about skull base or vascular in 6 weeks. Okay, and they continue to do DC. And they'll continue to do DC instead of doing DC. If one would put microsurgery into trauma, you do DC, but try to get into some skull base. Try to open, the cisterns. This is what people used to do earlier in India. If you ask the Amazonians, the CMC Velour guys, all of these guys used to go and cut the tent, used to drill the temporal base, and even take the temporal lobe off till the cisterns were reached. All this is dead now. This is not going on right now. And you will have trials like DECRA, Rescue ICP, Dead ICP, Risen ICP, and these are all billion-dollar trials where our data collectors sit and make make merry of themselves and present in big conferences and become kings. And the young residents, you see these young neurosurgeons from Africa, South America, they publish in these hallowed journals with all their p-values. They will not be knowing how to operate, but they think they're big. It's not true. It's completely wrong. So this has to go away. You have to start operating. You have to start understanding what is microsurgery. So the story of discovery of cisternostomy is very simple. I mistook a trauma for an aneurysm. This is done in Kerala. Probably Raja might know. Aleppi Medical College. Okay, that's where I worked after my residency. I came there. I wanted to do aneurysms. So I had finished my fellowship from Japan the first time I went, and I thought I could do aneurysms. And I wanted to do aneurysm, so I mistook. I mean, I had an aneurysm and a trauma, and I asked this guy to put in the aneurysm first. It was the weekend, so I wanted the aneurysm first. And of course, this was 2007, 2008, so we didn't have smartphones with all the funny features. So I just got a text message saying there's an aneurysm and a trauma subdural. So I asked the aneurysm to be put in. When there, my guy, the chap who was assisting me, is not very communicative. I asked for the microscope. Sitting there, the brain was very angry. So I opened all the cisterns, went in subfrontal, opened the opticocarotid, opened. It was, it was very tight. But after I did everything, the brain was lax, and I started looking for the aneurysm. There was no aneurysm. After about 1 hour, I started to panic, and I asked this guy, I can't see any aneurysm, and this guy tells me it's a trauma. I told him something. Of course, I cannot tell you that right now, but I was very angry, and I told him, okay, if it's trauma, you put the bone flap out. And I came back later in the night and did that aneurysm. But next day, the brain was lax. It was not like in a drum, as in DZ. In DZ, next day you see the flap. It's like a drum, okay, and it's really tense. So this guy's brain was not tense, and he was all set to be extubated. He was struggling. So that is not usually the scene that you see with a DZ, and that's what got me thinking. And 2009. We had our first series presented in Adam Brooks. I remember how the Brits laughed at it. I'm sure they don't do that anymore. So I remember presenting it in Cambridge, and of course everybody was amused. I didn't have any operative pictures. I didn't have a microscope with a camera, so I had to record that scenes from outside with a TRV, one of those big video cameras. It was not very clear. I didn't have the p-values. I didn't have the data. All I had was my enthusiasm jumping up and down and saying this is magic. Okay, and of course we figured out that it's not really magic. We figured out where we should do it, where we should not do it. We made a lot of mistakes. We made a lot of enemies, very little friends. But we went on for 13 years, and now here we are. So let's start off with a few cases, a few of our first cases. Look at this scan, okay? Look at this scan, see how bad it is, all right? There is no cisterns at all. There are contusions. This brain is going to herniate on the left side, okay? The CP angle cistern is widened. The brain stem is looking compressed. There is subarachnoid hemorrhage. So you can see this is a really bad scan, okay? This is one of those times when we used to do a large flap and then bite off the entire temporal part of the bone after doing a cisternostomy. So that's what you can see. You can see on the top, here on the top, you can see some bone, okay? And you can see the main thing is the cisterns are all open, okay? That is the main thing. The cisterns are all open, all right? And you can see that the contusion is not really removed. But the main difference is the cisterns are open. That's the main difference, okay? And you see what happens to this guy, okay?
Huh?
So these were the magical cases which led us to believe that this is something which will change. And I remember showing these about maybe 7 or 8 years before to Vladimir, maybe in Indonesia or someplace. I remember, and he was all the time, he was telling me, no kidding, no kidding. I remember that. I remember sitting down with him in the hotel and showing him this. You know, at that time, whenever I got the chance to show it to somebody, I always used to show it to somebody, okay? This is another case. You can see the CP angle cistern is widened. You can see the hematoma. You can see, I mean, this is a clear-cut DZ case. I mean, the CP angle cistern on this side is widened. This patient is going for herniation, okay? And this is how it is. So you have a small extradural underneath, but the hematoma, this hematoma is not really removed, but most of the other hematomas came out after opening the dura, and you ask for a Valsalva. These hematomas usually come out after you do the cisternostomy, of course, not before you do the cisternostomy. So another one, you can see how much midline shift there is. Okay, acute subdural contusions. This CP angle cistern is not only widened, it's herniated. You can see the herniation there. You can see the parahippocampal gyrus is herniated there. Can you see that? It's clearly seen that the parahippocampal gyrus is herniated. And this is after cisternostomy. This is the guy. Okay, he is in the ward, and this is the guy. Another one, acute subdural contusions, GCS of 7/15, right pupil dilated. That's how it is after cisternostomy. Another one, very, very bad brain swelling, thin subdural and very bad brain swelling. This is how it is. See this case, okay, this lady, GCS of 4, E1, V1, M2, bilaterally fixed dilated pupils. She had a posterior fossa hematoma, so we took it out, but you see the brain stem. You see the dural hemorrhages there. You see the blackening, okay, the relative blackening of the cortex, okay? So this brain, I mean, I can show you some of these surgeries. They're not pretty. The brain comes out like toothpaste. You're opening at the base and the basifrontal brain is going to come out at you, but it's a leap of faith. You have to get into the cisterns. This is something that we are educated against, okay? We try to open as max as possible and get out the brain as max as possible out, but no, open little, let that brain come out, you'll get into the cisterns and the scene is different then. You can see the amount of retraction we had to do. You see that? That is retraction injury. That was not there before, okay? But you see the brain is much less tight. And you see her with the oculomotor palsy. With the oculomotor palsy, you can see her with the oculomotor palsy. You can see the cisternal drain sitting there. Another one, okay, post-op. Another one after surgery. It was a very, very bad case. Okay, this is after post-op. I just wanted to show you the brain is sitting here without the brain going out or anything. Okay, so many contusions that we have not removed, so much of edema pre-op, but the bone flap is sitting there without any problem, without any issues after cisternostomy. This is the guy. See another one. See another one. Recent one. Okay, this, see acute subdural, subarachnoid, burst lobe, everything, whatever you can think of. There's herniation starting there. The CP angle cistern is widened there. You can see the CP angle, ipsilateral CP angle cistern. the pons is pushed back and to the other side, herniation starting there. It's a clear-cut case of DC, clear-cut case of DC. That is after cisternostomy, okay? That is after cisternostomy, okay? This is when she was transferred from the ICU. She came to my office, and this is how she is, okay? We have not even removed the stitches here. You can see the edema there, okay? And that's a drain sitting there, okay? There's another one, acute subdural, just like the first photograph that I showed you, all right? Cisternostomy performed, and this is how it is, okay? This is another one, okay? Very bad frontotemporal contusion, subdural, cisternostomy performed, okay? Another one. I'm showing you all types of cases, okay? All types of cases so that you understand. This is done by one of the consultants from Delhi, okay? This boy sent it to me saying that, you know, once this was the pre-op scan, he opened up thinking he would do a contusectomy, and this is what happened to the brain, okay? And then he went into the base of the brain. Fortunately, he had done a craniotomy so that he could get access the base of the brain. He didn't keep the bone flap back, but you see the brain is not bulging out, okay? This patient made a very, very good recovery, okay? And he ended up not taking the contusion. That is the funniest part of it. That's a contusion sitting there. He just did the cisternostomy. He didn't even put the drain. Another one, pretty bad, okay? One side extradural, one side burst lobe, okay? After the extradural is taken out, okay, now you can see how lax the brain is on the other side. This is from Czech Republic, just to show that the ICP dropped from 48 to 11. This guy sent me the picture saying the ICP dropped from 48 to 11. This look at the mass effect and midline shift here. Acute subdural, subarachnoid, okay, almost herniated patient. Okay, look at the brainstem. Okay, clear-cut DC in this case, and you know, GCS7 pre-op, how these patients are going to do. You see that, what has happened? Okay, bone kept back, post-op, first day extubated. You know, I hope some of my fellows from South America, Middle East here in this conference, they can tell you how we do and how early these patients get extubated. We don't keep them beyond 48 hours. And if the GCS is very low, if the GCS was very low to start with, like M2 and M3, we do an early track and, you know, take them out of the ventilator. And this is another case, okay, cisternostomy. Another one, acute subdural cisternostomy. This is done just 2 or 3 days back. You can see this case. See this. This is done by my boys. My consultants is in Biratnagar. I'm not even there in Biratnagar. I'm in the farm. So this is done by Prakash and Pramod. You see the temporal contusion, the burst slope there, the acute subdural. See the midline shift. See the midline shift. Massive midline shift. You see that? And you see, this is when they opened the acute subdural, was like that, just like you saw in the first picture. But here, instead of waiting or trying to close, they opened the cisterns, and that's a basilar artery, that's a carotid, that's the optic nerve. You can see that's the optic nerve, that's a carotid, that's the opticocarotid cistern being opened. That's the PCP, that's a third nerve, that is the carotid, that's the A1, that's the optic nerve, and that's your basilar. That's the end point of cisternostomy. Okay, so that is how the brain was. Okay, after doing the cisternostomy, that's how the brain was. Now, why does cisternostomy work? Why does it work? It is because of CSF shift edema. What is CSF shift edema? We didn't know all this before. We didn't know all this before. Okay, what is CSF shift edema? Now you must understand that in the cisterns are the CSF. Okay, and from the cisterns, the vessels go into the brain. All the vessels, they go into the brain from the cisterns. Now there is a space around these vessels. So these are Virchow-Robin spaces, and this is how the CSF communicates with the brain. There are purposes for the CSF. There are purposes, two purposes, cleaning and cooling. The CSF from the cisterns actually cleans and cools. We'll discuss about that. Okay. So the CSF from the cisterns goes into the Virchow-Robin spaces. Is there evidence? Oh yes, there is a lot of evidence right now. When I started talking about this in 2007, people laughed at me because I was thinking, how did in a trauma, in 2 hours, you don't see any cisterns at all. Where did the 120 ml of CSF go? People told me it went into the spinal canal. Impossible. Because if it went into the spinal canal, the pressures in the spinal canal would be so high. And that is not what Cocker found out. Cocker did a LP to these patients in trauma, and he found that the spinal pressures are not increased. So that is why he said, if there are signs of raised intracranial pressure and the CSF pressure is not increased, let us decompress the brain. Wrong statement, wrong facts, but of course, that was 100 years back. Stupidity, surgery based on stupidity, okay? So, but we know it is not like that. So it never went into the spinal canal. Where did it go to? It went into the Virchow-Robin spaces, guys. That is what is CSF shift edema. And if it went into the Virchow-Robin space, how did it go into the Virchow-Robin space? Because in the cisterns, there is bleeding. Because the most common thing to happen in trauma is subarachnoid hemorrhage. And when you have subarachnoid hemorrhage, it's a newcomer. And this newcomer comes with a lot of pressure. So, and this newcomer, the blood cannot go into Virchow-Robin spaces because the Virchow-Robin spaces are small. So the only thing that can shift into the Virchow-Robin spaces is the CSF. And therefore, the CSF shifts into the Virchow-Robin spaces and produces something like a CSF shift edema. Okay? And that edematous, you see, about 120 ml of fluid went into the brain. So you're making a 12 centimeter craniotomy through which the brain comes out at least about 1 centimeter. And that is exactly the amount of CSF that went in. And you're allowing the brain to herniate out, causing axonal damage, stretch, everything. And you're causing that brain to shift out, herniate out, thereby managing the ICP, where the intraparenchymal pressure is not being managed. Intraparenchymal pressure is what kills. So do we have experimental evidence? Yes. So Calgary, they did a weight drop model, and they wanted to find out what we were talking about. The CSF shift edema, is it true or not? If it was true, they would find subarachnoid hemorrhage and they would find fluid within the brain. So they found titubated hyperintensity 15 minutes after the trauma. They found titubated hyperintensity, and they did histopathology, and they found subarachnoid hemorrhage, and they found fluid shift into the brain. Okay, read this paper, extremely interesting paper, Garnet Sutherland and Sanju Lama. And many people ask me, why don't you do an EVD? Okay, now let's see. This is where they injected markers into the ventricle, okay, and waited for 30 minutes. Nothing, no communication of parenchyma and ventricle. They injected intracisternally and see how it's lighting up. So there is no communication between the parenchyma and the ventricle. How does ventricle ventricle, taking out 2 ml from the ventricle, how does it help? This is where you should understand what is compliance and what happens at, I mean, if you go to the right on a compliance curve, what happens? Even a little bit of CSF, 1 ml of CSF at the rightmost end of the compliance curve, even 1 ml of CSF, if it's added, that will result in very high pressures. Take a balloon and start blowing into it. It will be very easy first. But as the balloon becomes full, to put in even 1 ml of air will be very difficult because the compliance of that balloon is almost finished. So therefore, if you take, it is the reverse thing also applies. If you take out 1 ml of CSF from that balloon, the pressure comes down significantly. So that is, so when you take out CSF from the brain, 2 ml of CSF from the brain, and decrease the pressure, intracranial pressure, what you are doing, you're playing around with the compliance curve. You're not really doing anything to the intraparenchymal pressure. Now, why is intraparenchymal pressure important? You know what? If you measure the ICP in an extradural hematoma, I'm sure it's going to be very high, but not the intraparenchymal pressure. That's why you can take out the extradural hematoma and the patient is completely okay. But the subdural hematoma, different, very different. The ICP may be only 25, but the outcome is very different. So that is why I'm telling you, you guys should let go of the term ICP. It's a very general term. It's like saying the intra-global pressure or something like that. It's very generalized. You should look at intraparenchymal pressure, okay? Intraparenchymal pressure. Intraparenchymal pressure is what you measure with your bolt, okay? That is what comes down with cisternostomy, all right? In DZ, that comes down, but at the expense of a lot of stretch injury. This is Iype talking about the G lymphatic system, saying that CSF enters the brain along the cortical and pial arteries.
Actually does so along very specific anatomical structures. There's a specialized anatomy that allows the CSF to move very quickly and very deep into the brain, exchanging with the fluid that's inside the brain and then moving out. So it's a much more efficient system.
Yeah, this is what he says about, this is one of our first evidences back in 2012. This study changed our perspective, okay? Now what happens? I'm going to show you an animation. That is a brain, that is a brain, that is the cisterns, and those are the VR spaces. So imagine when there is subarachnoid hemorrhage, what happens? The cisternal pressure increases and the fluid shifts into the brain, and that's what happens. So if cisternostomy, you are actually opening the cisterns and causing a reverse of this fluid. And you can see this in surgeries. I'm sure all of you, those who've done cisternostomy, you can see the CSF filling up. And that is what you do with DZ. The edematous brain, instead of addressing the cisterns, you are opening on top, and that's exactly what you see. That's exactly what you do. All right? Not good. Now, how do you get into the base of the brain in an edematous brain? Very simple. You follow skull base principles. Vlad will tell you about that. Parthiban will tell you about that. Any aneurysm surgeon will tell you about that. Any skull base surgeon will tell you about that. You cannot do that in the second year of your neurosurgery. Don't even think about that. You need training for this surgery, like training for every other surgery. It is not like, I'm doing decompressive hemicraniectomy today. Tomorrow, can I do cisternostomy? No, sorry. Tomorrow, can you do basilar tips? No. So tomorrow you cannot do cisternostomy also. Of course, we are willing to train you. We're willing to give you the training for that. It is, instead of saying it's impossible, of course, don't listen to these data collectors. They cannot probably do an extradural, right? Okay, they're pretty good at collecting data. All your trauma surgeons who are on top, Those guys who are not going into theaters, who are collecting your data and presenting it in international conferences as part of trials, don't listen to them. Listen to skull-based surgeons, listen to aneurysm surgeons, ask them, how do you get into the base? Okay, aneurysm surgeons are not going to be inclined to come to trauma. I'm sure Vlad will not go to trauma. I mean, it'll be very difficult to grab Vlad and drag him to theater for a trauma, but this is exactly what you need to do. Okay, grab him to theater, ask him how to get into the base, and they will show you. And then you will be able to open the cisterns. You don't listen to your trauma surgeons. Take the surgeons out of the trauma surgeons. They are trauma data collectors. They are not going to help you. Don't listen to them. These are the ways how you get into the base. I'm not showing the videos. These are pretty bad cisternostomies. These videos are available. I'm sure Hira will send you links. These are the indication scores that we published in World Neurosurgery. This is a very interesting finding. The ipsilateral CP angle cistern widened is very important. So we don't wait for these patients to cook in the ICU under the intensivist. And when he throws his hands up and saying that the patient, the body is starting to smell, then we take up for decompressive hemicraniectomy. This is not what we do. Cisternostomy is a proactive surgery, okay? So the indications are there. We don't wait till everything is lost. If you do that, of course, if you do that for aneurysm, if you do that for a tumor, if you do that for anything, everything is lost. So when the CP angle cistern starts widening, this is an indication that the patient is going into herniation. Not just this, but you have other scores as well, like GCS, like absence of supratentorial cisterns. All that, along with ipsilateral CP angle cistern widening, is a very, very important sign. If you have that, start taking up these patients for cisternostomy, because after the herniation, even if you do cisternostomy, your chances of salvaging this patient is pretty less. These are our outcomes, all available in papers. We have this in Chinese Journal of Traumatology. This is primarily because we send it to all the big journals, but big journals have these big editors also, these so-called trauma surgeons who never steps into theater, who, if you ask them to do an aneurysm or something, I mean, I'm sure they'll have a heart attack or something. But they're pretty good with p-values and stuff. So they are sitting as editorial, they're not even class. I mean, I feel that they're not qualified to look at papers like cisternostomy, because these are new things. They need to come here. They need to stay with us. They need to see this paper. They need to see these surgeries. And only then they're classified, they're qualified to talk about. I hear so many stupid comments, completely stupid comments, as the people who edit or review these papers. I mean, some of these reviewers' comments are atrocious. And, that is why we have to publish in these kind of journals. I'm sure this trend will change once we get accepted a little bit more. So these are the papers, these are the chapters, papers from all over the world, from Iraq, from Brazil, from Switzerland. I mean, Roy and his group has done a fantastic study. And of course, there have been critiques also. The biggest critique is that incompetence, that not everybody is equipped to do a cisternostomy. What kind of stupid excuse is that? I don't understand. I mean, can you say that for aneurysm surgery? Can you say that for skull-based surgery? Not everybody is equipped for skull-based surgery. Therefore, I mean, not everybody is equipped for aneurysm surgery. So let's do a decompressive hemicraniectomy. And that is the critique, I'm telling you. So this is the biggest load in the world, okay? Not basilar tips or not aneurysms. You're seeing this almost every day, in and out. As I speak, I'm sure many neurosurgeons all over the world are operating on trauma. But the biggest critique is that our residents are not equipped to do cisternostomy. It's a stupid, lame excuse. Okay, don't fall for that. Learn to open. Okay. So this is a Geno study. Finally, we got into that, and they're finally a lot of kindness to put us as one of the options. Okay. Earlier they outlawed us, but now with Angelos, Corrado, Franco, all these good friends in the committee, they have put as one of the options. So if you're doing cisternostomy, you're not going to be arrested. So now Shabarish is coming out with a online registry and multicentral trial. I'm sure Shabarish can lead a multicentral online registry based in the US and a multicentral trial. And of course, I mean, I should tell you about the brain cooling and cleaning also after with this. You know, we figured that the CSF goes into the brain from the cisterns. We were wondering why. And that is when we figured out that it goes and cools and cleans the brain. So we did this is a hypothesis. You know, sometimes your mind is much better than the lab. And what is there in your mind has to be confirmed in a lab instead of going and looking in the lab, going to the lab without anything in mind. So that is called a hypothesis. So we hypothesized that the sinuses, you know, the sinuses like the sphenoid, the ethmoid, the maxillary, they're all in this region. They are all around the suprasellar cistern, you see, and they're lined with wet mucosa. It's like you wearing a sweater, which you're sweating with your clothes and you're sitting under a fan. Imagine when you're breathing, that's a fan. And these wet clothes, the mucosa, they're getting evaporating. And they were evaporating. You see, when they are evaporating, what happens is the sinuses are getting cooled. If you take a thermal map of the face, the coolest parts are the sinuses. And of course, the suprasellar cistern is right in center of these sinuses. So the CSF is cooled more than 1 to 1.5 degrees centigrade. And then the vessels, they go into the Virchow-Robin spaces and they are pulsating all the time, you see. So that is the Archimedes pump principle, Archimedes screw principle, you know. So the Archimedes screw principle, the cisterns, it's not the capillary action. The vessels are pumping, and then where the vessels are pumping, what happens is the CSF gets drawn into the brain. It gets pumped into the brain. What a beautiful system you see. And that is how the brain gets cooled. And in the night when you're sleeping, the aquaporin 4 channels open, and this CSF gets intermixed with the ISF of the brain. I mean, these papers are out already, okay? And that is how the brain is cleaned. So the cleaning is something that happens only in the night, while the cooling is happening every single time. In cooling, the CSF is not getting mixed with the ISF, but in the cleaning process, the CSF is getting cleaned with the ISF. I mean, getting mixed with the ISF. You see, what a beautiful system. What an amazing system. Okay, so you can read up brain cooling and cleaning. We have a few chapters in the Springer Neuro series and Intech Open and all that. These are all available on the net. And this is a G lymphatic system. This is the pulsations which drive the CSF into the brain. And if you see, the first sign in Alzheimer's is that the pulsatility of these vessels are lost. Okay, so this opens a lot of options towards degenerative and other diseases as well. That is Voralex. She gave us a beautiful illustration of how, how the brain is cooled and cleaned. This is our chapter in the Springer Neuro series. This is a chapter in the Intech. Thank you very much. I'll stop sharing.
Thank you very much, Professor Iype, for this wonderful talk, this novel and unique theory of cisternostomy. We are very grateful to have you today and learned a lot. Professor Vladimir Benis, would you like to give your expert comments?
It's pleasure. I've known Iype for many years, and I always am enjoying his company. You know, I visited his place in Biratnagar and in Chitwan, and he has visited Prague. He actually has been even in this house where I'm sitting now, trying to swim against the current of my pool, and he was one of the two guys who managed, actually. So he's very strong, not only physically, but also mentally. And I love this concept of cisternostomy. And the reason is not only the enthusiasm of Iype Cherian. The reason is my experience with aneurysms and subarachnoid hemorrhage. Because what you do in ruptured aneurysm is actually cisternostomy. It's exactly the same procedure. You are only in a, let's say, more or less better anatomical conditions because brain is not that much damaged. And we all have seen profits for the patients from this cleaning of the basal cisterns, from opening of the lamina terminalis, from leaving the brain in the interpeduncular cistern, whatever you name it, whatever means opening the basal cistern to the clear CSF is beneficial for the patient. I also fully understand the burdens which Iype is encountering while trying to promote this procedure. It's exactly as he has said, the lobby of trauma surgeons who really are in the decompressive business only and in ICP measurements only and in all these p-values randomized trials. And it's exactly as he says, that the only argument against cisternostomy from this side is the expertise of the surgeon. It's really stupid. You can be expert on carpal tunnel, and the other one wouldn't be expert on carpal tunnel, and he will be doing AVMs and everything, but he of course will not be able to do carpal tunnel because he never did one. So this is not the argument which I hear. And I've been directly involved with pushing the article of Roy Daniels and his co-workers from Lausanne, who did not a randomized study, but they have controlled study of cisternostomy with quite a lot of the patients. And it was really well seen that the cisternostomy at least should be studied if you are not a believer. And really, the difficulty to get this article published in ACTA was tremendous. It was surprising the antagonism of the trauma lobby. I'm not going to name the names, but I guess Iype has shown them on one of his slides, even the reply by the guys when the article was finally published. And this is the exact image of what will be happening, that they will be fighting against this because they really never ever have seen the base of the brain. On the other hand, I'm a believer by Iype. I really believe in it. It's combination of Iype's enthusiasm and my experience with subarachnoid hemorrhage. And I'm also a friend of all new ideas. The ideas about the CSF flow, how it's reabsorbed and how it goes back to the brain. It's excellent. So in general, if you wouldn't be willing or anyone wouldn't be willing to use this procedure for trauma patients, at least he should think about it, and at least he or she should be open to arguments. And I believe that these arguments will be stopped only when the randomized trial will be run, because this is the only feature to which all these trauma surgeons understand. Easy for them, very simple, p-values and all that. You probably would recall quite a long time ago, there was a randomized trial on ICP monitoring, which really wasn't in favor of monitoring. And it was exactly the same situation as now, that they formed a strong front against this one single randomized trial. But there is always some time to start, some time to organize ourselves, or we do who believe into the procedure, and do some work. Iype. It's a suggestion for you. And I hope that this procedure will be here with us, and I believe that it will be slowly accepted, because I strongly believe that this is a bright idea and this is really surgery which may help the patients.
Yeah, but before that, we'll just have few comments from Professor Atul Goyal. Professor
Oh,
Atul Goyal. Professor Atul
You
Goyal.
know,
Yeah.
Atul,
oh, Vlad, nice to hear your comments.
nice to meet you again. Great.
You know what? I will like to talk about this subject because I have been thinking about it for a long time. And I know one thing I can tell you, Iype, one new idea, one small little idea is bigger than 1,000 people operating for 1,000 years with the same old thing. You know, idea. This is one idea. You can never undermine an idea. That is my basic understanding. And as far as this cisternostomy is concerned, you see, I know I has been trying to uh, develop this idea and trying to promote this idea for last 15 years. And there is no question, there is no question he has succeeded in introducing this concept in the whole world. There is no concept. And last year in the World Federation of Neurological Surgery meeting in China, there was one full session on cisternostomy. And this, no major meeting will introduce one huge session for this particular subject if there is a huge controversy. And also in various forums, various platforms, various meetings, I have been seeing this concept has been introduced, and there are many believers and many people in the world are now doing, and this is almost like an accepted concept. And Iype has been, instrumental in introducing a bright new idea to the world of neurosurgery, to the world of trauma, and it is for the world to either, ignore it or take it. The main issue which I have a feeling is, as you rightly pointed out repeatedly, to open the cisterns in a compact, in a tight little brain when the trauma occurs. How to do that is one thing which many people may not be able to do. The other thing that you will appreciate, for a long time I'm saying about water. Water is life. And if you see a grain of wheat and try to chew it, break it with your teeth will break, but the wheat grain will not break. You put a small little small little drop of water, and next day a green sapling emerges from that wheat. The powers of water and power of how it creates life, and how it, if there is a tumor in the posterior fossa, how the ventricles develop and how the ventricles become big, and how they help tackle that situation of race, that introduction of a new pathology in the brain. It is for us to see and understand. And as far as I am concerned, I will like to ask you two questions, Iype. One is this concept. One, before I go to my questions, I have two questions. One is, I will go to my question first. What do you think about the pressure regulation in the cisterns? That is one thing. What do you think about the intraventricular pressure, even if the ventricles are compressed? What is your take on that? What happens to the intraventricular CSF pressure, even if the ventricles may be chinked or small? Can you answer that question, Iype?
Yeah, I really don't know. It's the same question that Professor Yasagil asked me when I presented this in Turkey 2 years back. He asked me the same question. I mean, I know you are somebody who thinks a level above a lot of other people. So I don't think the answer to this is there in any papers, because after Professor Yasagil asked me, I went to look at all the available literature. There is no available literature in what is the normal ventricular pressure, what is it in relation to cisternal pressure, and when the ventricles are compressed. See, now I can tell you, sir, one thing. When we had trauma, one of my seniors did a study. I mean, he did a study about Dr. Jacob Matthew. He is in Cochin. He did a study about the variation of intraventricular pressure in trauma. So he put in this ventricular catheter in every trauma that came to CMC during my time, and he studied the pressures. Of course, the pressures were elevated when we brought down, when we took CSF 2 ml of CSF. The pressures, I mean, it drastically fell down, and this is all because of the compliance curve. This has been studied very well, but in relation to the cisternal pressure, what is the ventricular pressure? What is the compressed ventricular pressure? I don't think there are any articles on it.
I will like to tell you about one story of my neurosurgical journey. I was, my friend in preventive and social medicine. He was professor of preventive and social medicine, and suddenly he developed a large thalamic bleed, thalamic. And and he was conscious and alert and all, and I decided to just conserve him. And after about 2 hours of conserving him, I got a call that he is in a bad shape, and I came back to operate him, to remove that clot. And before I was reaching that, because he had completely, he had become zero. So I was trying to play around with the area, and suddenly when I opened the cisterns, they opened like a jet, and the whole brain relaxed. You understand what I'm saying? And then I remembered you at that time about cisternostomy. That is one. Second thing I will tell you is my concept about trauma and concept about decompressive craniectomies. It is also a very, very uh, widely done procedure, decompressive craniectomies for trauma. And I have been, although if I say I don't like decompressive craniectomies, there will be hundreds of people in the audience also, they will come out with weapons and hit me. But no matter what, I am completely and absolutely against this procedure of decompression as a process in trauma. Completely, no matter what anyone says. I have tried this in various meetings when I say, no, I don't like it, and I have suffered. But whether I suffer or not suffer, that is for people to decide. But I do not like decompression, and that is one thing that will remain with me. And you know what? Your main contribution in this story of cisternostomy is that you avoid this procedure of decompressive craniectomy. And that is a huge contribution to the patient, huge contribution. You see, you are doing what has to be done. Of course, you will also not say that trauma, when the brain has suffered very huge injury, that all patients you can save by this procedure. I don't think you will ever say that. But if some patients you are able to avoid this procedure of decompression, and by this, and that is a huge contribution. My feeling is, what do you have to say about this?
So when we started out, we thought it was magic and it will save every single patient. But we realized later on that what are the limitations for it. The main limitations right now, what I think, is if there is ischemia due to the trauma. So if the pressures were very high, ICP was very high, and the patient has already developed ischemia, then cisternostomy will not help. But otherwise, most of these brain swellings, it's going to help bring down the ICP. We can put the bone flap back, but depending on the initial GCS, if the initial GCS was very bad, the time to rehab is going to be much more. But I can only say that it's far, far better compared to decompressive. As you said, decompressive is not a good surgery. It's a surgery which is outdated, which is done its time, and it should be outdated. I get a lot of young neurosurgeons telling me that it's an easy surgery. But I mean, as all the pioneers, all the best neurosurgeons in this audience, either whether it is you, whether it is Vlad, whether it is anybody in this audience who has gone to the next level, they will tell you, they will tell the young neurosurgeons how difficult it is to go to the next level. Every level up is different. Professor Goyal, I have seen him from the time I was a resident. And we have admired him. We have gone to his presentations, listening to pre-op, post-op, pre-op, post-op, pre-op, post-op. I mean, there were magical pictures, you know, huge tumors taken out. This is not easy. This is not easy. This is not, he didn't go into surgery and straight away start taking out these tumors the same way. I mean, cisternostomy, when you have an easy option, always water flows through that easy option. That is, most of the guys would like to sit down and do that easy option. But this is definitely not an easy option. And when we have people like Vlad and Professor Goyal here and would tell us how bad decompression is for the patients and why we should not take this easy option, I mean, that makes a lot of sense. Everybody needs to be trained. I mean, these young residents who are not doing cisternostomy should go to places and get trained. And that is the only way we can, I mean, do away with decompressive at the drop of a hat. And these trauma surgeons, these lobbies, they should be put to their place. They should be shown their place. That's very important.
You know what? I have one similar situation, but before I come to that situation, I will not like to, you know, I know many people, other people in the audience who want to ask questions. Let them ask questions. Then I will come to a similar situation as you rightly said. So I am waiting for others to finish, and then I will come back with my.
Definitely, we'll come back to you, Professor. Your comments are very valued to us. We'll come back to you, sure. There is a few questions which has popped up on the chat that from Warlex Fusunjang, who has asked which systems that we need to access. That is first question. And the second is, does posterior clinoidectomy need to be drilled? In which conditions? These are two questions.
You know, the first thing first, I'll try to say about the posterior clinoidectomy. I'm sure Vlad will be rolling, rolling on the floor with laughter, because, you know, when I started, I realized that trauma surgery is very simple. And so my mindset was, let's do everything in skull base and make this into the most complicated surgery. This is how my mind works, okay? It is probably a disability of my mind. So posterior clinoidectomy is very, very rare, extremely rare, okay? I mean, these days in cisternostomies, we hardly do posterior clinoidectomy, but when you can do that for a basilar, why not do it for a trauma? Why is trauma different from basilar tip aneurysm? So my answer is almost never. Posterior clinoidectomy needs to be done almost never. But if it needs to be done, you should know how to do it. All right. So we have, I mean, and the funny thing is, when I started doing cisternostomies, I started putting up these videos of posterior clinoidectomy just to make sure that I put off people by who says that, oh, this is very simple. Okay, I just wanted to put them off, but it worked against me actually. So I remember, I'm sure Vlad will remember my videos 7 or 8 years back when I was doing. Everybody used to talk only about the posterior clinoidectomy. Okay, I'm sure, I'm glad that thing came up right now also, but let me answer you, it's almost rare. Now, with regards to cisterns, when you do a sagittal unlocking, that is removing the sphenoid ridge all the way up to the superior orbital fissure, you are literally next to the optic nerve and the carotid. You are next to the opticocarotid cistern. So you open there, you're getting into you open there, you retract the frontal lobe away from the orbital roof, you literally into the opticocarotid cistern. That is the first cistern you need to open and wash out. Let the basifrontal brain come out, no problem. Put patties, get into the cistern, wash out the blood, see the optic nerve, see the carotid, go lateral to the carotid. If you can, see the third nerve. most of the time the temporal lobe would be coming over the third nerve and even sometimes up to the carotid. No problem. You take out, retract the frontal lobe, get the optic nerve, get the carotid, wash out all the blood there, open all the arachnoid there, and then between the opticocarotid window or lateral to the carotid, try and open with a small guarded suction, try and open the membrane of the liquus gently. And if you can do that, put in a drain into that place, get out. That is your cisternostomy. Okay, that will take care of, by that, your brain, if it's lax, put the bone flap back. If the brain is not lax, no problem. For almost 300 of those cases, I didn't put the bone flap back. I didn't have the confidence to put the bone flap back. I'm sure you won't need 300 cases, but you will need maybe 30 cases. So do a DC with cisternostomy first. When you're doing a DC, open the cisterns first. And then after that, when you're confident that the brain is lax and you've opened the membrane of the liquus very well, go ahead and put your bone flap back. Then you're into full cisternostomy.
We'll first finish up these questions which have been popping up on the chat. There is one, Radoslav Hansel, I believe he's from Russia. He's asked, do you perform cisternostomy also a typical hemorrhage like decompensate lenticulo-capsular hemorrhage with significant midline shift?
Yeah, see, we started doing endoscopic evacuation for those kind of hematomas, and these days we just go with a small port and the endoscope and evacuate these hematomas. But before that, yes, when I used to do transsylvian evacuation, I always used to open the sil cisterns first, so that the brain is completely lax, and then go transsylvian and evacuate these hematomas. That is much more easier than having a tight brain and doing the sylvian dissection. So yes, we used to do it for those kind of hematomas maybe a few years back. But after the endoscope, after we started the port endoscopic evacuation, I feel it's much better, and you can do a much better job rather than doing a cisternostomy and a transsylvian.
Please, Professor Benes,
you know, from aneurysm surgery, there are people who are routinely opening the ventricle, the third ventricle, the lamina terminalis. And that's true that if you open the lamina terminalis, you get out of the third ventricle quite a considerable amount of CSF, and the brain becomes lax. Why don't you open the lamina in trauma patients?
Yeah, so Vlad, we used to do that before. In fact, we used to open the cisterns and then open the lamina terminalis also. But we figured that if there is no ventricular blood, we are introducing ventricular blood into the third ventricle. There was no need for it, and the ventricular blood is not a good thing. So what we did is, instead of that, if you can open the membrane of Lilliquist, I would ask these guys who are opening lamina terminalis just to go lateral to the carotid, open the membrane of Lilliquist. You get much more CSF than you can ever get out of the third ventricle. Yeah. And in trauma, it is not like aneurysm. Aneurysms, usually you have hydrocephalus. Usually you will have a minimal hydrocephalus, but trauma, these ventricles are really squashed. So it is always better to open the membrane of Lilliquist, and that CSF is going to be there. So once you open that, you get a lot of blood out, and then you wash that, and the brain becomes really lax.
I don't believe in lamina terminalis as well. I don't open it in aneurysms. You know, I just know that there are people who are doing that. Actually, there is not that much of CSF in the chiasmatic cistern. Once you open the carotid cistern, that is the most important one. There's a lot of CSF, and then, of course, Lilliquist membrane. And from aneurysm surgery, I have an experience that if you do not get the CSF out of the carotid cistern and the brain doesn't become relaxed, the patient will be doing badly.
Yes, absolutely.
Yeah. Is it the same with cisternostomy in trauma?
Yes, absolutely. So you need to wash out the entire blood completely, all the blood, wash it out, open all the cisterns, put in a drain, even put in a drain for 5 days. So again, putting in a drain can be, we figured that out by our mistakes, that on the first day till the drain is bloody, we keep it on the bed level. After that, over drainage also kills the patient. So what you should do is keep that at 15 centimeter height. This is very important because earlier we used to overdrain, and then these patients developed unexplained edema. So this is also there. So what we need to do is we should keep the drain at the bed level till the CSF turns clear. So if it's next day, by next day morning, the CSF is usually clear. And next day morning, you have to keep it at 15 centimeter height. So that prevents over drainage. So this is also important. And thanks, Vlad, for bringing that out.
Mhm.
Yeah, perfect. Thank you very much. Professor Azmi wants to ask a question. Professor Azmi Ilyas, can you come in?
Hi.
Hey,
How are you?
Azmi. Absolutely good, Azmi. Long time, man.
Okay. Yeah, good to see you again. I enjoy your presentation very much. Congratulations for your great works. So I have a couple of questions, but most of it already answered in the previous discussion, but only left one question.
Yes,
so do
please.
you have any experience in children in doing this cisternostomy, because their anatomy are much smaller and the brain are more fragile, and the etiology in trauma are slightly different as compared to adults? So what is your answer to that?
Excellent question, Asmi. We had a, documented series of 51 patients. I can send you the data. These cisterns are really difficult to get into. They are literally a surgical disaster, believe me. So when you try to get into these cisterns, it's really, really difficult. It's tight brain. It's it's not like the adult brain, but if we remove a lot of skull base and try to get into these, but once you get into these cisterns, it's a completely different issue. And these children do very well. We have, the BBC has done a documentary, and one of these girls are featured there. How her academic, they have looked at her academic gradings, everything. And these children do fantastically well, but they do decompressive also. They do fantastically well. Once the initial part is over, children, for everything they do, you take out an entire hemisphere also, they do very well. So I cannot attribute that to cisternostomy, but once we do this and the child is better, then you're looking at a fantastic result.
Perfect. Thank you.
Okay, thank you very much. Thank you.
Thank you. Professor Parthivan, would you like to come in, sir?
Yeah,
Your expert comments. Tell me.
Yeah, it's fine that I've been hearing this. I've been very lovely to see my friends and Iype, and we are also doing quite a bit of cisternostomies in India. It's getting popular, right? It's getting popular, and many neurosurgeons are now doing it. So some of my paper is still waiting. At any time it may be coming out. So eagerly waiting for that. I was asking me to show one classical video, and I can show for the newcomers and the younger generation to see the technique. And I have I can show you two videos. Now this kind, you can see the right frontal hemorrhage, and there is a intracerebral hemorrhage. And you can see one side is the pre-operative, the other side is post-operative. Now I'll show you the video for this. You can see here, this is the clot there. And first you have to remove the clot. This after the patient is ventilated, remove the clot nicely. And after that, you have to retract the frontal lobe. You can see the optic nerve very nicely. There's not much of a retractor I'm using in this. You can see only the cottonoids, and dissect it gently. That is at the interoptic systems. And meticulously do this arachnoid dissection. Like I was telling, it's like aneurysm surgery. Like Vlad was talking about. Now how you do the aneurysm, you can see the pituitary stalk there. And while you do the dissection, you keep doing a lot of saline, keep on pouring saline, and slowly dissect. You can see this CSF gushing. And now lateral to the carotids, gently. Basically, it's a microsurgical technique. You have to be a microsurgeon. You are a microsurgeon. As a young surgeon, you start learning here. Very gentle. You can see the blood mixed CSF. It keeps coming. And again, now beautifully you can form, you can see the space between the optic nerve and carotid, and there you can see the liliquist. And you can open the liliquist in any technique you are used to. The moment you open the liliquist, you are into the, you know, you can see the basilar there very beautifully, and there is also blood. And keep on pouring saline. When you keep pouring saline, you find it is very much relaxed, the brain gets relaxed. So this particular video is specially prepared in this, is very popular among all the students. Many people keep looking at this, particularly now when you are becoming a specialist in aneurysm surgery. And brain trauma, actually more than aneurysms, we do more of brain trauma for all the young neurosurgeons. That is the interoptic space. You can see the pituitary stalk, and all the systems you can open up gently, meticulously, and keep on doing hydrodissection. Once you keep on doing the hydrodissection, you can see the brain just falls back slowly and slowly. So what you need is the patience. As we all said that, you know, just throwing out the bone in a trauma is very simple, but you just have to wait for some time and do a beautiful microsurgery. You can get the CSF coming out, and that does a great job for the edema is concerned. Can I show one more video if you have time?
Yeah, sure. Quickly,
Yeah,
sure. Yeah, please.
I'll show you one more video, a little bit faster one here. Okay. Now here you can see this is Cherian approach. The other one I showed you, this is a slightly faster video, a fast moving video. This is a Cherian approach. The other one was the subfrontal approach, a Cherian approach. To see the dissection, there'll be plenty, there quite a significant subarachnoid hemorrhage will be there in head injury. So there is not, I'm not using any retractor, please, very, very important here. Everyone asks, how do you go to the base of the skull? It's very simple. You drill the lesser wing sphenoid, drill very nicely, and then you can easily go. There you can see, there you can see the PC, you can see lateral to the optic nerve. Now that is the A1 there. Most of the time you use a cottonoid for your dissection. You keep dissecting, keep on putting saline, keep dissecting lateral to the optic. Do reach the, you can see the liliquis deeper to that. This is a fast moving video. Please don't think that it is pretty fast, but it is a fast moving video. It is speeded up. Now I'm just showing the technique, how you can go there without a retractor. There is no self-retaining retractor. It's just, you have to use your suction and your bayonet, sharp bayonet forceps, and keep on pouring saline and saline and saline. And after doing all these things, I'll show you how the brain is. That is most important. Now, whatever you see is now in the microsurgery. Now keep on focusing there. You don't need to see the brain, how it is going on. You just keep doing. Now look at the brain. Now look at the brain. The brain is so lax here now. In spite it is contused, there is a contusion, but then look at the brain. It's quite lax. You can put back the bone. That's what I wanted to show you, these two videos, so that you can appreciate better. So somebody has asked question, and which way to go, subfrontal, anterional, anyway. But one thing is that you have to reach the optic nerve. You have to reach the optic nerve. From there, it is absolutely microsurgery. Cisternostomy is a microsurgical trauma procedure. Thank you very much.
Thank you, Professor Parthiban. That was an excellent video demonstration of the technique of system. So, Professor Goel, we are back to you. Your final comments, Professor?
No, final is going to come by people who are going to do this procedure. And I'm sure there is no doubt that slowly, surely, but definitely. And what I, suddenly remembered that, decompressive craniectomy is a very easy even a very junior most resident can do a decompressive craniectomies and all those things. But easy does not means the best.
Yeah.
Like I wanted to give a parallel to that. Like many of you know about my concept on Chiari malformation. And decompression is a very easy technique. Like you do foramen magnum decompression is a very easy technique. But foramen magnum decompression is not the technique at all. If the technique is to do, as you probably know about my concept, that it is atlantoaxial instability and atlantoaxial fixation is the treatment. But it is not easy to do atlantoaxial fixation. So decompression is a easy procedure, but it is not a correct procedure. It is a wrong procedure. It is a dangerous procedure. Whether the similar concept holds true in decompression for trauma is a question that everybody should answer. But for me, decompression is not the answer at all in trauma of any kind. Whether cisternostomy is the answer, time will tell. But what we have seen in the last 10 years and the number of people now adopting this procedure all over the world, from various countries to various countries, my feeling is eventually the truth will be told by what people see and what people realize and how the patients respond. And I can only wish Iype and his concept my best and very, very, very best wishes. Iype.
Thank you, Professor.
Thank
Professor Jyotish wants to comment. Professor Jyotish, please.
Hi.
Hey,
Yeah, please.
before Jyotish comments, I'll tell you one. Jyotish is from was in Kottayam Medical College. Same Jyotish, right?
Yeah.
It's
Now
the
in
same.
Trivandrum. Right.
Jyotish taught me to put the first stitch when I was an intern. Jyotish taught me to put my first stitch. So I'm very
You
glad
still
that.
remember that? Okay. Yeah. Right. Okay. My question is: do you advocate this procedure for malignant MCA infarcts?
No. It doesn't work at all. We have done it for about 12, 13 cases, and finally the neurologist, because I had to go in the night and they'll take out the bone flap, the neurologist finally stopped referring cases to me. So it doesn't work at all. Everything will be well for some time. When you open the cisterns, the brain will go lax and all that, but you will have to take out the bone flap. But in the night, you will be called, and more than 80% of cases. So we figured that CSF shift edema is not the reason that these brains are swelling. So it is probably something else, maybe cytotoxic or something like that. It doesn't work for malignant infarct.
Okay, congrats, Iype, for wonderful presentation.
Thank you.
Thank you, Professor Jyotish. In continuation to that subject, I would like to comment that recently Macon Nadergaard, who is the founder of the lymphatic system, they came up with an article in this January telling that in infarct also it is the same principle of edema that takes place. If your technique works in trauma, why not does it work in infarct? Because the principle is the same as elucidated by Nadergaard et al.
See, we started the cisternostomy for, trauma as well as for infarct at the same time, maybe in 2007. Maybe my technique was not very good at that time. Maybe I was not opening membrane of liquors. I don't know. But since it did not work for me, I just didn't do it at all. So I really cannot comment whether, it didn't work for me. That is all I can say. I am aware of Nadergaard's paper, and I saw that in, they have published in Science also one paper regarding this. But maybe people should start doing it and seeing it whether it will work or not. But for me, it did not work, and I stopped doing it long time back. So I would not be in a position to tell you categorically.
Perfect. Thank you. Now, Professor Sabarish Natarajan would like to tell about his registry. Professor Sabarish?
Thank you for,
please.
it's an honor to be part of this astute faculty group here. my experience with cisternostomy is not like Iype. You know, I've been doing it for 3 or 4 years, but watching him do it and watching all of you do it has, you know, made me develop it into a different. The most important tenets is I love Jyoti Parthiban's video. You know, I do it just like microsurgery. You know, the moment I open the cranium, I do not open the entire dura. Because the moment you open the dura, your CSF shift edema gets the brain all the way up on your face. You don't want that. You want to do a small subfrontal dural opening, treat it like an aneurysm, go right to the cistern. Opening the optical carotid cistern is very important. Opening the liliquist is more important than that. After that, unfortunately, I'm working in the American system where I cannot not leave the bone flap off, right? Because, you know, you're guided by what you have to do by data, and, you know, you have to answer to the critical care specialists who are not surgeons, who take care of your patients in the ICU. So I have to leave my bone flap off. And I always curse myself, why did I do that? But I have to. I hopefully at some point will have data that I don't need to. The second thing I was thinking, Rajat mentioned about that paper about malignant MCA infarct. I have been doing in malignant MCA infarct, when I see the brain come out, I go in and open the cisterns, and I see the brain goes down significantly lower. Yep. But as I said, I have to leave the craniotomy off. I have to do a craniectomy. And every time I've been successful is when I open the liliquous membrane. So I think that's something that needs to be revisited as a second project after we prove this for TBI. Okay. And the third place where I think it is very important is patients with bad grade subarachnoid hemorrhage. Today, there's a lot of bad grade subarachnoid hemorrhages where the patients are being coiled, and these patients are put in with an EVD and left in the ICU. I think some form of minimally invasive cisternostomy in these patients is going to improve the outcomes in these patients and have a better outcome after cisternostomy, after coiling of poor grade subarachnoid hemorrhages, which we don't do at this point, right? So I think that's where it needs to go, but we need to establish this in TBI. But I'm a strong believer. I think it's going to be there, but we need to create data, and we need to edge to that golden day when we can perform cisternostomy without fear. Right?
Please tell us about your registry.
Correct. So I think the most important, you know, we've been talking to Iype a long time about, you know, what to do, how to do about this. I think we need to create a prospective registry with data sets of, you know, what is the patient's, you know, baseline GCS score, motor score, pupillary score, what is their contusion, subdural hematoma, midline shift, what is their cisternal effacement, kind of ape what happens in the global neurotrauma outcome study, and have a prospective registry where people can de-identify patients and send data in. I'm trying to set up a REDCap registry where, you know, we can create an IRB, and we'll send this to all institutions, and you can online register these patients prospectively, and we look at outcomes of these patients and how these patients do, you know, including ICU stay, ventilation stay, what is their Glasgow outcome score at 6 weeks, and see how these patients do. And this is just a comparison. And then for people who put the cranium back, what is the conversion rate of doing a craniectomy after that? So I think that is the first step. The other comment I want to make is I know that everyone has to do trauma, so everyone has to learn how to do this. But to keep this as a safe and proven procedure, I think it's important to have expertise doing this, experts doing this, aneurysm surgeons and skull-based surgeons doing this as the first go to prove the concept before we disseminate it to every neurosurgeon, right? Because if we disseminate it to every neurosurgeon and let everyone do it, the problem is the quality is not going to be good, and we're going to lose the battle of proving that this works for our patients.
Yeah, please, yeah. Dr. Benes, please.
We are talking decompressive craniotomies here and decompressions, but I hate them. Atul, I fully agree. I hate this procedure. But should it be really decompression? Then you must encompass frontal, temporal, and even occipital region. That must be a huge, huge craniectomy. I don't believe that anyone is doing like that at the very beginning. We all start with frontotemporal craniotomy, something like an enlarged pterional, and then go down to the skull base. Iype, what do you think about this? When you really want to have a decompression, then you must go really for a big craniotomy.
So it's like this. So you have about 100 ml of CSF entering the brain. You have to compensate for that. And if you calculate, it's so funny. If you calculate 12 to 13 centimeters, as Vlad said, if you calculate 12 into 13 into 1, okay, you are about you are about that amount. 1 centimeter is how much the brain comes out, and you take an average of that, and 12 into 13 centimeter craniotomy, that compensates for the amount of CSF that went in. But the problem is that brain is literally herniating out, and the axon, that is what happens if you see those, that after 6 months, that brain which herniated out will go to 30% of its volume, because there is so much of damage that has been done. And if you see, after decompression, when the patients come back after 6 months, there is nothing left. Everything is gone down. That brain is literally wasted away. So as he said, decompression is, I mean, it's a surgery which will, if you say that in a slightly hurtful manner, what I used to tell my residents were that you converting a cemetery to a vegetable market. Okay, there is nothing else that you're doing. You just you're converting a cemetery to a vegetable market.
Perfect. I think we had a very good discussion today. We all live in the age of evidence-based medicine. Probably Professor Sabri's registry would bring in some new evidence into this matter. Until then, it will remain as an investigational mode of therapy in traumatic brain injuries, because mortality has never been come down by any of these measures. Anyway, I would like to wind up this session. We had a very good discussion. Thank you, Professor Benes, for chairing this session. Thank you, Professor Iype Cherian, for this beautiful demonstration. Thank you, Professor Jyoti Parthiban, for coming in. Professor Sabris, on behalf of the Education Committee and Professor Yoko Kato, I really thank everyone to have a very fruitful discussion on this topic.